Good evening, everyone. We welcome you all for this No Thrombosis webinar series. This is a live inbox workshop series. So this is the another chapter of this No Thrombosis platform. So I'll just share my screen to introduce today's faculty. I hope my screen is visible. Ankit, just let me know if
yes.
So today we are having with us the eminent, the expert moderator, Dr. Prashant Mishra sir. Sir has done MBBS, DNB in General Medicine, DNB in Cardiology, PDF in Interventional Cardiology, FSCAI, FESC, and sir is consultant cardiologist associated with Dinanath Mangeshkar Hospital, Pune. Today we are having with us an eminent speaker, Dr. Gauri Karmarkar Madam. Dr. Gauri Madam had done MBBS, DNB in General Medicine. Ma'am is senior resident at Dinanath Mangeshkar Hospital, Pune. So with this, I welcome our moderator Prashant Mishra sir and Dr. Gauri. And over to you, sir. I'll share the screen once you allow me.
Thank you for those who have joined us. It's a Saturday evening. Unfortunately, even in spite of the COVID being gone away now, for those who have dedicated their time, we will try and make it a short meeting. Nevertheless, but this is a very exciting molecule that we have. And it is such an exciting molecule that I anticipate that it will be used very commonly. Till recently, it was a very expensive drug and therefore it wasn't used as much. But with many companies, including our current host today, Emcure Pharmaceuticals, coming up with a molecule available to our patients at a very reasonable cost, I believe the usage of this drug is going to go up. Nevertheless, even in spite of the fact that it is a wonderful drug, every drug is only as good as how it is used. If used correctly, in the correct patient, in the correct indication, at the correct dose, this drug can be life-saving. But the same drug, if it is misused in a wrong patient, in a wrong dose, can be catastrophic. Over the next 20 minutes, my colleague, Dr. Gauri Karmarkar, will present a case. That case is a real-life case. It's a case that is not a fictitious case, it's a real case. And it has several lessons with usage of apixaban in daily usage in patients with atrial fibrillation. So with this, we start. And we'll try and do a good academic meeting over the next 30 minutes.
I'll share the screen, sir. I hope the screen is visible.
Yes. Make it.
Good evening, everybody. Can you hear me?
Yes.
Yeah, unfortunately, I'm not able to start my video, but I'll start with the case. Is that okay?
Yes, it's okay.
Yeah. So here we are going through a. Can we take the next slide, please?
Yeah.
Yeah. So here is the case from our hospital about a patient who has a 72-year-old lady, diabetic, has undergone coronary artery bypass grafting 3 years ago, and who has fair ejection fraction of 55%, who is on a treatment of aspirin 75 milligram and atorvastatin 10 milligram once daily with bisoprolol of 2.5 milligrams once in a day. So she happened to see physician for her urinary tract infection, and the physician got to know that she has this irregular pulse, that is, she was in atrial fibrillation, with her ventricular rate was around 94 per minute. So her CHADS2 score found to be 3, that is more than 2. So she needed anticoagulation for stroke prevention. And from the physician, she was started on apixaban 2.5 milligrams twice daily. Next slide, please. Now, 2 months later, she got admitted with left upper limb and lower limb tingling and dizziness. Her ECG was still having persistent atrial fibrillation with controlled rate, that is 83 per minute. And for the neurological symptoms, the neurology and cardiology consultation was taken. And when the neurologist saw the patient, it was a symptom was suggestive of transient ischemic attack. MRI brain was done, which showed the small lacunar stroke, and MRI angio was showing minor atherosclerosis. From the cardiology point of view, when the examination was done, her overall scenario was she was post CABG 3 years. Echo was from ejection fraction point of view was same. Ejection fraction was 55%. Patient was not having any angina symptoms. Her atrial fibrillation with controlled ventricular rate and CHADS to VAS score now was 5 because she has undergone the cardiovascular accident in the form of TIA, which adds up the 0.2 in her CHADS to VAS score. So now she is 72 years old. Her creatinine is 1.2 and her weight is 66 kgs. So right now she is on aspirin 75 milligrams and atorvastatin 10 milligrams once daily, bisoprolol 2.5 milligrams once daily, and apixaban 2.5 milligrams twice daily. That is morning and evening dose. Next slide. So currently patient, as I said earlier, is on single antiplatelet and statin plus bisoprolol plus 2.5 milligram dose of apixaban. That is half of the standard dose that has been prescribed for a patient whose weight is more than 60 kilogram, creatinine is less than 1.5, and whose age is less than 80. That is 5 milligrams twice daily is the standard apixaban dose that has been recommended for stroke prevention in patients with non-valvular atrial fibrillation. So now we suggest the change in her drug therapy. That is, now it's been 3 years post CABG. So as per the current recommendations, we can stop aspirin. We can increase her atorvastatin to 40 as the MRI angio shows evidence of atherosclerosis. There is increased dose of bisoprolol to 5 milligram once daily, as her heart rate is still around 85 to 95. We can still lower it down to the 70 or between 70 to 80, which gives more benefit to the heart. And we can correct the apixaban dose to 5 milligrams twice daily, which is the appropriate dose considering her age, weight, and serum creatinine level.
I think Gauri will have some discussion on this slide.
Yes.
It's not very uncommon to get these combinations of aspirin with statin, and they're very popular. They are very, very commonly utilized. But the thing here in this patient was that this patient has had a CABG. So we are looking at secondary prevention. And 10 milligrams of atorvastatin is really inadequate for most patients of secondary prevention. And therefore, the atorvastatin dosage was increased. There is very little evidence to suggest utilizing antiplatelet with an anticoagulant like apixaban beyond 1 year of the revascularization. So there was no point in giving aspirin. That aspirin will only add to the bleeding, I think, right?
Yes.
That is the reason why I think it was stopped. And bisoprolol for adequate rate control. We are trying to aim a heart rate of close to 70 when you are trying to at resting heart rate of 70 to get what to call it a good controlled ventricular rate for most patients. And the correction of the apixaban dose. I think you have more to tell us about what is the correct dose of apixaban. So this was a patient who got a stroke in spite of being on apixaban. So that is important. The patient got a stroke in spite of apixaban because probably it was on inadequate dose of apixaban.
Yes, sir.
Please, Gauri, go ahead.
Yeah. So please, next slide. So here we are going through certain data that we have. So this is the pool data from worldwide data that we have got. So 78% of the patients are the ones who are appropriately dosed, that is, whose renal function is normal, whose weight is more than 60 kg, and whose age is less than 80. For them, the standard dose is 5 milligrams twice daily. So 78% of the people are getting the appropriate dose, but the 12% of the people, which is a big number considering the worldwide data, are still underdosed. That is, even though they don't have any renal issue, or if the age and weight do favor the adequate dose of apixaban, still they are underdosed. Either they are kept on 2.5 milligrams BD instead of 5 milligrams, or some other form of inappropriate dosing, but not as per the recommendation. Now, when it comes to the renal patients with renal dysfunction, so the renal indication for reduced dose, that is create 1.5. So the 4% of people are overdose, like they need dose reduction for their renal function, like for example 2.5 milligrams twice daily, but they are still given 5 milligrams daily, and the 16% are still the patients who need appropriate dosing that's adequate, but they're still underdosed. So here we are discussing the all over the data where apixaban has to be given in a correct dose, either it is over dosed or underdosed. So in the down false chart, we are seeing here that all three NOACs like apixaban, dabigatran, and rivaroxaban, when we are studying the pool data for these drugs, and when we compare it against the placebo, then there is certain amount of risk of still presenting with thromboembolic complications, but compared to the placebo, there is significant risk of major or minor bleeding. But when we separate this data into individual apixaban and dabigatran and rivaroxaban, we got to know that the major contributor for this data is the inappropriate dosing of apixaban. When we see the data where inappropriate dose of apixaban has been prescribed, the complications of thromboembolic stroke are significant. We don't see such with dabigatran or rivaroxaban. So what we are trying to say here is the inappropriate dose of apixaban is the major contributor for thromboembolic complications, systemic embolism, and stroke. Yeah. So if sir wants to add anything to this.
I said, amongst the three NOACs, the data for apixaban is possibly the most persuasive. And the only reason we were not utilizing it so much in our patients was because it was at a prohibitive cost till recently. But this is Western data. These are educated people. These are developed countries. And even there, you could make out that 3 times more physicians were likely to give the smaller dose because they feared producing bleeding in their patients. So there is a tendency on part of us physicians to underdose. And when it comes to antithrombotic therapy, especially with apixaban, this may result in poor outcomes for our patient. Apixaban itself is such a safe molecule that we should actually be using the correct dose, which is 5 milligram BID for an overwhelming majority. And when we use the correct dose, we get the good results. The 2.5 milligram BID dosing is more prescribed than it is really indicated for. It is indicated only in very selected group of patients. And I think you will be speaking more about where we have to use this small dose. And when you use it in that group, we get good results. But for other patients, use the 5 milligram BID dosage because the 2.5 milligram BID dosing does not protect the patient. And it actually only gives them the extra bleeding risk. It does not prevent the strokes. So yes, if it is used inappropriately. Apixaban is a wonderful drug, but when it is used in the correct dose for the correct patient. That is how it should be. So please continue. Please continue.
Yes. So next slide, please. So here we are actually seeing the difference between apixaban 5 milligrams twice daily versus apixaban 2.5 milligrams twice daily. This is the data we are getting from Aristotle trial, also including the patients with advanced renal disease and patients with atrial, of course, with the patients with atrial fibrillation. So here we are studying the patients who are on a appropriate dose of apixaban, that is 5 milligrams twice daily. There is a significant reduction in the evidence of stroke and significant there is no much significant bleeding with the appropriate dose of apixaban, and accordingly the reduced rate of death in such group of patients. But if we are using the apixaban in a 2.5 milligrams of dose, we are not getting help with the prevention of stroke and systemic embolism and accordingly the death. But we are definitely increasing the risk of bleeding in these patients because it is definitely going to cause intracranial bleeding or GI bleeding. So there is no help with stroke and systemic embolism prevention, but we are unnecessarily increasing the risk of bleeding in these patients by giving 2.5 milligrams of dose. So neither we have the benefit of stroke and systemic embolism prevention, plus we are adding up to the bleeding risk in these patients. So we are, by decreasing the dose of apixaban, we are not really helping them with the increased risk of bleeding, but actually we are unnecessarily putting patients into the risk of bleeding and not on any benefit for stroke or systemic embolism prevention. So, can we have the next slide? So here is the recommendations for a long-term treatment of patients with atrial fibrillation and oral anticoagulant therapy after revascularization or acute coronary syndrome. So let's say the group of people who has went through acute coronary syndrome and has undergone, so they have been put on triple therapy for the first 3 months, that is NOAC plus aspirin plus clopidogrel. So after 3 months of completion of this treatment, say for patients of ACS, with the 6 months of completion of this treatment, they can safely be converted to double therapy, that is NOAC plus either aspirin or clopidogrel for the next 6 months. And after 6 months, after finishing of 1 year of antiplatelet plus NOAC therapy, we can safely convert them to the NOAC monotherapy. So instead of putting them on antiplatelet, single oral anticoagulant, we can safely continue. That is apixaban 5 milligrams twice daily doses will be sufficient for them. And those who have undergone elective PCI, say for the patients with stress test positive and have undergone the elective PCI. So for them, recommendation for the triple therapy, that is NOAC plus aspirin plus clopidogrel, is for 1 month. And for the next 1 year, we can continue with the double therapy, that is NOAC plus either aspirin or clopidogrel, and they can safely be switched to the single monotherapy of anticoagulant after 1 year. So those are the
this patient was 3 years post bypass. Traditionally, our normal routine patient, we give them aspirin. But because this patient had an independent indication of NOAC, it was logical to stop the aspirin. Continuing both aspirin as well as the NOAC in this patient 3 years down after the bypass would only add to bleeding risk. It does not give them benefit of either therapy. It only adds to bleeding risk. So beyond 1 year of revascularization or ACS, the guidelines today endorse usage only of NOAC. You don't require an additional antiplatelet for most patients. So this, I hope, is the take-home message for the physicians.
Yes, sir. Yeah. So the last slide of this. Okay. So here we'll just quickly revise the take-home message. So apixaban, 5 milligrams twice daily with or without food. 2.5 milligram twice daily in those patients who are either of the 3 characteristics, either age is more than 80, body weight less than 60 kg, or serum creatinine more than 1.5. If 2 of these 3 are present in any of the patients, then they are the candidates who require reduction in the dose of apixaban, that is 2.5 milligrams twice daily. So right drug in a right dose is likely have this desired benefit, and inappropriate NOAC dosing is not uncommon, just like Sir said. So NOAC monotherapy in atrial fibrillation, that is with no concomitant antiplatelets beyond 1 year post revascularization for coronary artery disease. So these 3 points we would like to emphasis on. And yes, so if Sir has to say anything.
Very well presented, Dr. Kavi.
Thank you, sir.
Yeah, very well presented. We are now spoiled for choices. We have 3 beautiful NOAC agents for patients with atrial fibrillation. Of this, for most cardiologists, I think apixaban is the safest, as well as it provides a good combination of safety as well as superiority over warfarin. And that is why it is so popular amongst cardiologists. But as she has rightly said, it is the right drug, but provided we use it in the right patient in the right dosage. So if you use the right dosage, and the right dosage is 5 milligram BID for the majority of the patient. Only if the patient meets 2 out of 3 criteria, and it's simple to remember: A, B, C. A for age more than 80, B for body weight less than 60 kilograms, and C, that is creatinine more than 1.5 milligram per deciliter. If you have 2 out of 3 of these criteria, only then do we require a reduced dose. Otherwise, all patients will get 5 milligram BID. Even if they are 1 out of these 3 criteria, they will get 5 milligram BID. That is the correct dosage of apixaban. And then when you use the correct dosage, you will get the desired results. It is not very uncommon for us as physicians to fear bleeding, because when a bleeding happens in a patient with NOAC, there is a feeling that we caused that bleeding. Whereas if the patient has a stroke, in spite of the drug, it is his bad luck. It is not because we did something wrong. So that is a feeling that physicians have all around the world. But what we know by now, that the bleeding risk with 2.5 milligram BID and 5 milligram BID is the same. But the protective benefit of 5 milligram BID is much better. So try and understand the correct dose is what is required for most patients. And beyond 1 year of revascularization, whether PCI or CABG, if the patient is on NOAC, we can safely skip the aspirin. We can safely skip the antiplatelet and continue the patient only on NOAC. That is the beauty of NOAC. It does not require INR monitoring. It adds to safety and it makes treatment so much simpler, provided we use them correctly.
Yes, sir.
Dr. Gauri, do you want to add something? Have you any more other experiences with bleedings in these patients?
So more than bleeding, sir, in the past 6-7 months of residency, I have experience of patients with atrial fibrillation and presenting with stroke, and all those were either not on anticoagulation or skipped though physician have started them on anticoagulation, they have stopped it or skipped it the dose, or the dose was inappropriate. So
so one part of the story has been made easy by the company. Like Emcure has now got at a reasonable price. One major reason why people skip medicines is cost. It was expensive, and now I think it has become reasonably affordable for our patients. So I hope they can take it. And the second part is physician inertia. I think we should have more education programs for physicians. They should know that this very effective therapy, which is safe for our patients, is now available. It is available at a reasonable cost in the interiors of our country. So it should be used very commonly. I really feel that people should not fear anticoagulation in the NOAC era. These drugs are not like warfarin. They are much more safer than warfarin. If we can even percolate that information to people, stroke can be devastating. A young patient getting stroke and getting paralyzed for life, it's miserable. So if we can get that message through, a great deal would be achieved.
Yes.
Sir, very nicely presented talk by Dr. Gauri. Just would like to, ask one question. If any patient has to be shifted from other NOVAC or the other the anticoagulant, is there any specific guidelines or any precaution need to be taken to the apixaban, other NOVAC to apixaban or other anticoagulant to apixaban, or vice versa?
One must have a persuasive reason to why you want to shift from one NOAC to another. If a person is perfectly doing on one particular NOAC, I'm unlikely to change that NOAC. So, but as Dr. Gauri said, many patients are not on a NOAC. And therefore, straight away, with a NOAC, you don't require bridging therapy with Clexane like we used to require with warfarin. So that you don't require. So what you can do is that you can just start the NOAC. It starts to work within a few hours of initiating it. And it has also got fast waning off. You stop the drug and within 3 half-lives, after 36 hours or 48 hours, the effect is gone. So even for a major surgery, the current guideline says stop the NOAC for maximum 48 hours before the procedure. That's the guideline, because NOACs are so predictable in their mechanism of action. So I don't think I would ever shift a patient on a particular NOAC if he's doing well to another NOAC. I don't see any good reason to do that. But 50% of the patients that I see are not on anticoagulation. And because people fear these drugs are similar to warfarin, which they are not. Warfarin is not a very ideal drug, but the NOACs have greatly bridged the need for the people. So majority concern would be that a person is not on anticoagulation and he should be on anticoagulation. And a NOAC, especially apixaban today available at a reasonable price, is possibly one of the better drugs.
Thank you, sir. Thank you, Dr. Gauri, for this very insightful talk on this important topic. Definitely all the participants, the delegates who have joined this program, who are watching this program, will be enlightened with the insights that you are given and Dr. Prashant sir has given. Sir, with your permission, I mean, should we call it
I think so.
Yeah.
I think so. People have joined on a Saturday. Let them enjoy the Saturdays also.
Sure.
Thank you for those who have
Thank you,
joined.
sir.
Thank you. Thank you.
Thank you.
Gauri,
Thank you
very
so
well
much, sir,
presented.
Prashant
Very
sir,
well
for
presented.
joining, for giving your valuable time. Thank you, Dr. Gauri, for giving your valuable time out of your busy schedule. And I would like to thank all the delegates also who are watching this live for giving their also valuable time from their busy schedule. Thank you so much.
Thank
Good
you.
night. Bye, sir.